So it's an honor, privilege to have Dr. Dalvis joining us. We're grateful that you accepted the invitation to talk about mentoring new trainees in the cath lab, and I think we're all looking forward to listening about your 5 tips for early career interventional cardiologists. I'm going to take some notes, hopefully.
Yeah, good morning, everybody, and Riz, thanks for your invitation. Really, when he invited me to give this talk, I was in two minds because this is a non-technical talk and I was not so sure whether I'll be able to do justice. But then I gathered courage and said yes, and hopefully I'll be able to convey my thoughts over next 15 minutes. So the title of my talk is to give my experience about training fellows or mentoring them, and to give you 5 tips to those who are young and new in practice of cardiac interventions. So let me begin with this preamble, which has a few disclaimers and few of my beliefs. This talk is not based on any scientific data, and I do not claim to be an ideal mentor. So I'm sorry to disappoint some of you who might have been here to listen to a scientific talk being given by an ideal or a great mentor. I do not think that you can train someone to be a mentor. You can either have those qualities or you don't have them. Mentoring is an art, and that is the reason why the most knowledgeable or the most popular amongst us do not necessarily end up as great mentors. What I'm going to do over the next few minutes is to reflect upon my experience as a mentor for over 3 decades. Mentoring means different things to different people. To me, it means providing guidance in acquiring knowledge and skill sets, and giving pragmatic advice to develop insight into what we do. It also means sharing experiences, the good, the bad, and the ugly, so that you strike a professional and a personal friendship between you and your trainees. And your trainees can use you as a sounding board, trying to discuss with you the professional and personal difficulties. So definitely, mentoring is much beyond the walls of the cath lab. To me, mentoring is somewhat like parenting. There has to be a sense of ownership, and it has to be bidirectional for the mentor as well as for the mentees. It involves hand-holding in the first few years, or first few months at least. Certainly, course correction and disciplining. If you cannot be corrected without being offended, you will never grow. I don't mean to say that you need to discipline day in and day out, because that will undermine their confidence. But if it has to be done, I think you should not shy away. It needs to be done. I think more importantly is encouragement, and not only in private, but in public. I feel that this is extremely important because it helps them build self-esteem. In the current era, where science and commerce go hand in hand, I think mentor should not shy away from imparting ethical values. And I have done it all through my mentoring career. What is required of a mentor? I think he or she should lead by example, because mentees will do what they see. In short, you have to walk the talk. There is nothing like a perfect mentor. I think a good mentor is one who has a great knowledge base, who is caring, who is compassionate, who has a lot of common sense and a good sense of judgment. Also, one who is passionate and driven and is able to foster an interest in learning by generating curiosity. I will go a step ahead. I think he should nudge the mentee out of his zone of comfort without undermining his confidence. When any trainee comes to me for the first time, I think this is what I call the first principle. I always tell them that interventions neither begin nor end in the cath lab. They begin much earlier and they end much later. So mentoring in the cath lab truly begins much before, right from the time you evaluate the patient. I think it is important that you tell your trainees to develop an art of listening. You must listen to the history very carefully, do a good and quick physical examination, look at the past medical records, they have much to teach, and do not jump onto the reports of investigations because these reports cannot be seen in isolation. They need to be seen in the background of the clinical picture. Simply put, we treat patients and not reports. Another important aspect is counseling the patient and the family, and this does not come easy. So I always request my trainees to sit with me when I am counseling the patients and the families. You need to be positive, but you need to be truthful. You must keep their expectations within acceptable limits. You necessarily need to be empathetic because the family as well as the patient is under a lot of stress and duress. Being indifferent generally in life does not help, and certainly in our profession, it cannot help. One of the most important things I tell my trainees is never sell a procedure. There are many I have seen, if you don't do this procedure, you will die. If you do this procedure, you will run a marathon the next day. It doesn't happen that way. So please do not try to sell a procedure. It is this concept is harmful to you, to your patient, and to your profession. I think the art of communication, which is never taught in any medical school, nor is it assessed in most of the schools or in most of the curricula in the developing world at least, I think is a very important aspect. And the earlier you learn the art of communication, better it is. The second important thing I tell my fellows is knowing the natural and unnatural history of the disease or of the abnormality that they are going to treat, because that helps you in assessing a risk-benefit ratio. It also makes you understand the indication for intervention. I always ask them, is this intervention going to change the quality of life? Is it going to prolong his life? Is it going to prevent dreadful complication? And if the answer is no to all these three questions, then the next question is, why are you intervening? Because there is no role for cosmetic interventions of the heart. Knowing the natural and unnatural history also helps you in timing the intervention, whether it is emergent, whether it is urgent, or whether it is elective. And my style of doing it is by asking challenging but non-threatening questions, because that keeps everybody on toes. And sometimes I ask a question, and to boost their confidence, I tell them that even I don't know the answer, so you better go and read, find it out, and let us discuss it tomorrow. Pre-procedural workup. So it's a habit to order investigations ranging from CBC to MRI. My style of working is I tell them to justify each one of the investigations. How did it help them? Right from CBC. Did it help them in establishing or changing their diagnosis? Did it help them prognosticate? Did it help them plan a management strategy or make that particular procedure safer? And if the answer to this is no, then the next question is, why did they order this investigation? So again, asking challenging but not threatening questions is helpful in keeping everybody on his or her toes. This is a learning pyramid, and you must be aware of this particular pyramid. So these are the retention rates, and this is what we call as the passive, the first 4 of them, and the last 3 of them are the participating ways of learning. So the retention rates with listening to a lecture or reading or audio visuals or seeing a demonstration are pretty low. But I think it's a very important aspect, the passive learning. And then of course, discussing, practicing it yourself and teaching, retention rates are much higher. And why both are important? Because what the mind does not know, the eyes won't see. So if you don't read, if you don't attend lectures, you will exactly not know what you are going to see. But I have extended this cliche, and I think what the eyes have not seen and what the hands have not done, the mind will not know. So both passive as well as participatory learning are equally important in becoming a good physician. Now, how do you mentor? I think Halsted, when he started the residency program in United States in late 19th century, his principle was see one, do one, and teach one. And the Kolb's model was more or less similar of observation, thinking, action, and experience. I think in today's era, I would take it a step forward. I would say see many, do many, and teach many. During Halsted's time, there was lack of opportunities. There were not so many programs. But in today's date, we cannot stop at seeing one, doing one, and teaching one because the opportunities are available. And also, in today's date, there is very little room for failure or complication. The patients and the families are really not willing to accept that particular aspect of failure. Now talking about intraprocedural mentoring. I think this is the most difficult part of mentoring. Allowing the trainee to do this far but no further, that decision is very crucial and very difficult at times, because taking it over from him or her will never, he or she will never be able to build that confidence. But if you wait for a complication which is irreversible, then that is harmful to the patient. So this has been the most difficult dilemma of my mentoring life. I am patient, but I don't know how patient I can be or I should be. This is about post-procedural care. In sports, you must have heard that the coach is telling the team, it isn't over till it is over. Unfortunately, in surgeries as well as in intervention, it isn't over even after it is over. So access site complications, temperature, hydration, renal injury, infections, these are all the issues which can crop up later. So it's not a great idea that a mentor, after finishing the procedure, just throws the gloves in the basket and walks out. I think, as I said, you have to walk the talk, and your trainees are going to do exactly what they see. So I like to see that every patient, till the time he or she is discharged or even beyond, is looked after in the same way as we look after in the cath lab. And now I come to the 5 tips that I've been asked to give to the early interventionists. So my tip number 1 is plan your work and work to your plan. The planning should start from anesthesia, access, position, the sheets you are going to use, the catheter, the wires, the angiographic views, the devices, balloons, stents, and what have you. And there also needs to be a backup plan. Believe me, in the absence of a well thought out plan, you will end up with multiple failures and complications. There is no room for randomness in the cath lab. My tip number 2, learn to expect the unexpected. So be physically, mentally, emotionally, and logistically prepared for complications. And if you are not one to be able to take complications in their stride, I think you should look for some other specialty. In interventions, the complications are going to happen. Unfortunately, complications never knock before coming. They come as a bolt from the blue, and that is why you should be ready all the time. Successes really don't define how great you are, but how you deal with complications separates men from boys. Whenever there is a complication, my advice is lead from the front. Do not let your mind get clouded with things like what will happen if this patient doesn't come out, what will be the medico-legal implications, who has done the mistake, what will happen to the billing of this patient. I think all these thoughts should be out of your mind. The single goal should be saving the patient, because human life is priceless. Tip number 3, never flout the basic principles. I think simple things like pushing against resistance, flushing without aspirating, not flushing the sheath during every cath exchange, not keeping the catheter below the heart or preferably underwater when the patient is not on IPPR. These are some of the simple things, but some of the most common complications and some of the most life-threatening complications can occur because you have flouted the basic principles. Catheterization is very much like driving. Initially you drive with caution, look left, look right. Once you are confident, then caution is left to winds, till such time you end up with a crash or a complication, and then back to caution. So my advice will be, never let your guard down. Do every case as if it is your first case. Tip number 4, ask for help and know when to stop. No one in this world knows everything. So seek help when required from interventional radiologists, interventional cardiologists, or surgeons, and seek it before it is too late. Failure is better, failure of a procedure, rather than having a complication. In today's date and era, doing a successful procedure but with a morbid or a dead patient is not only not meaningful, but is not acceptable. So I think the bottom line is you must know when to stop. And lastly, audit your work. Doing 1,000 cases is meaningful only if you have sat back to audit your work. If you have no time to audit your work, doing 1,000 cases is like doing one case 1,000 times, because you are likely to repeat the same mistakes over and over again. And to tell you, our memory, a human memory, is a memory of convenience with respect to success and failures. We tend to remember our successes, but tend to forget our failures. So it is important to have a very objective third-person audit. And this is the last slide that is looking beyond, and this is to the early career interventionists. Scientific rules, which are more or less dogmas, need to be questioned. So my advice to you would be, don't follow rules, but learn to break them. The second important thing is, don't accept status quo. Learn to move out of your comfort zone, like I have done today, by moving out of my comfort zone by addressing you on this particular topic. And lastly, don't fear failure. I don't mean to say failure of the procedure, failure in life. It is better to have tried and failed rather than not having tried at all. These are my mantras for progress. Thanks for your patient hearing, ladies and gentlemen.
I don't know what I say after that. It's a phenomenal talk. I think I really enjoyed it. I don't know, Chetan, if you want to make some comments on that, but I mean, I'm still processing all of that information, but it was amazing.
I think the whole session has been very stimulating. But Bharat, I think the person like you with your experience kind of thing, I think we a lot of times we do feel that thinking, how much do you let the trainee do? Where do you stop? And that is something which kind of, the more time you spend with the trainee, that's when you kind of learn that actually you can allow them to do certain things and certain things you have to take over. But it is very likely we will get it wrong sometimes.
Oh, absolutely. And I think that also depends upon the abilities of the trainee. As you see them evolve, you know that you can take this much liberty with them. So I think it's a process in continuum. And also for a mentor, when I was younger, as young as you probably, I was a little restless and little impatient. As I grow older, I become much more patient, and also knowing how far I can go with this trainee, that is how I decide. But I definitely cannot put my hand on my chest and say that I'm always right. It's possible that sometimes I'm a little premature, and it's also possible sometimes I wonder if I would have taken over a little earlier, this would not have happened.
Dr. Dalvi, it's an excellent talk and really stimulating. I want to ask you a question, if you don't mind. As there is no ideal mentor, probably there's no ideal mentee, but from your experience, what attributes would you be looking in a mentee, who is in the cath lab with you? Could you share some thoughts?
Yeah, I think the first and foremost is his level of enthusiasm. I like people to be enthusiastic about learning. Second thing I look at is his the fire in his belly to do things, to improve. And I think that if he has, and of course, his honesty in accepting the mistakes or in accepting when the things go wrong. So I think these three qualities of honesty, being enthusiastic, and having a fire in the belly to succeed or to do things. I think if these qualities are there, I would be happy to take over anybody, irrespective of what is his background in terms of his information base or in terms of his social, cultural, financial issues. I think this I would consider as one of the best mentee.
Thank you, sir. Sachin?
Hi, Bharat. Thank you. Very stimulating and thoughtful talk. And I can ask two questions in being in two positions. One is which Atul already addressed to. And what would you, the second part of that question would be, what would you say is a quality where you would think this is not possible to mentor somebody? And how would you address that issue? And the second part is from the mentee's point of view, what should they look in a mentor? And that is challenging for people moving institutions, countries, cities sometimes. It's such a short time for somebody to choose. Most often it is based on, I want to learn this procedure or I want to be in this institution. So it is quite a challenging state. And the generation is changing, and you're right, it's the way people look at life is changing. We are seeing a new generation of trainees coming up. And what is your view of mentors accepting the change so that we don't actually lose out on mentees, because they will actually live life differently, if I may put it that way?
Yeah, I think, Sachin, this is a great question, and I think it's very, it requires some amount of thinking. I'm really glad to see some of them, like Sachin or Chetan. I was their mentor when they were in KEM Hospital. And I'll tell you very frankly, things have changed enormously. Really speaking, when I was in training or when they were in training, the duration of work was never an issue. Or telling a student or a trainee to do one particular thing was never an issue. And I rarely remember them questioning me as to why I make them work for more than 12 hours or 13 hours or whatever number of hours, or why this work has been assigned to me. But I was lucky in that sense to have people who never questioned. And I think that to some extent it is required. To some extent, if you think that something right is not being done, to discipline is required. I'm not trying to say that you discipline them every day or you make them feel, feel not too good about it. But I think to some extent that is required, and unfortunately it is going away. So I think mentoring is also going to evolve over a period of time, and people will have to adjust to the needs of the time, as you very rightly said, because their lifestyle is different, their way of working is different, life-work balance, as Gareth referred to, that is becoming different. And I'm not sure that I have a solution, but I think over a period of time, the newer mentors will be able to find that solution. I can only say about myself that I was extremely lucky in having such great trainees or students that that I could do what I thought was right under those circumstances. And as far as the second question is concerned, I'm not sure as to whether today mentees have choice. They can probably go to one center, to another center, and they usually go with this thought that I would love to learn this procedure or that procedure. I think there is much more to life and to interventional pediatric cardiology than learning a procedure. My advice would be to, rather than only going to learn a procedure, I think you must go to learn a way of life, the values, the way people think, the way people ask questions. I think that is very, very important. I tell you, one of the most turning points in my life has been trip to Boston Children's. I would say that it was one of the most turning points. It is not because it was Boston Children's, but because that is a place where I learned what to do, what not to do. And also I learned that I was not that bad. I saw what excellence is. So it's not that somebody taught me, held my hand or something like that. It was just the environment. And I think that is very important, that the environment that you learn in and from whom you learn. I think there are many things apart from just the procedures.
We have one more question.
Yeah.
A comment.
So I want to ask something. So there is something called as the circle of competence, a concept of circle of competence. Have you come across some of your trainees, or do you believe that certain person is not cut out for a work or say complex interventions?
Yeah, I think there is, and as you may not be able to make that decision on day one, but over a period of time, maybe over a period of few months, you will be able to make out that. And I think there is a way of subtly telling the trainees that this is not something which you should involve yourself in for these reasons. And you may not tell him directly. First you may suggest, and slowly they will also know that this is probably not the place, they are at the wrong place. And if they are able to take the clue and change their ways, I think it's good. If not, if they insist that they want to be there, then probably you have to be really cautious while mentoring them, especially intra-procedural mentoring. But of course, there is definitely a big spectrum as far as the competence is concerned amongst the trainees. No denying that.
Prof. Masood, did you have a question or comment, or has it been asked? Okay, I think we've.
Thank you.
I think we'll probably leave it at that comment. Thanks everyone for the PICES session. I think it's been I'm biased, but I think it's been an absolutely fantastic session.
No, yeah.
I've learned a lot.